There are things that are driving healthcare costs in the US, and those things are inevitable. For instance, the cost of medical innovation, like all this AI, technology, data management that you're talking about. But then there is also this other part. Are always concerned, with all of this technological advancement, is going to just continue to widen the gap between those who can afford this cutting edge care and those who would not. How do we now strike that balance of making sure that this innovation that is inevitable would continue, but at the same time that we are ensuring that rural American people are not priced out of or left out of quality care because of this high technological advancement that we're seeing? Hello and welcome. This is Rethinking Rural Health Financing. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together we are uncovering the stories, the challenges, and the innovations that is shaping healthcare in overlooked communities. In this series, we ask hard questions about how money moves, who gets funding, who gets saved, who gets served, and who gets excluded. From policy to practice, we explore what healthcare financing should look like. Joining me today is Dr. Marschall Runge. He serves as the Executive Vice President of the Medical Affairs at the University of Michigan. He's also the Dean of the Medical School and the CEO of Michigan Medicine. He earned his doctorate in molecular biology from Vanderbilt University and his medical degree from Johns Hopkins University of Medicine, School of Medicine, where he completed his residency in internal medicine before going on to do a cardiology fellowship at the Massachusetts General Hospital. Dr. Runge has authored over 250 publications and holds 5 patents for novel approaches to healthcare. His newest book, which is very important for our conversation today, The Great Healthcare Disruption, really leans into how new collaborations between big tech and bold policy thinking could shape the future of American healthcare. One interesting thing about him is that he's a Texas native who has spent over 15 years in North Carolina, and he's also someone who clearly enjoys a good thriller. He would say that he has experienced so much you can't make this up moment in real life that moving into writing fictional work almost felt inevitable. So it's a privilege for us to have him here. Welcome to What About Rural Health, Dr. Runge.
It's a privilege to be on your podcast with you. So thank you very much. I really am a huge supporter and advocate for rural health. I think it's an area where we haven't done as well as we could. And so I'm glad for what you're doing.
Thank you so much. I appreciate that. And I know that before we started off officially, we were talking about the weather in Michigan and Chicago, and Michigan is somewhere here, and look at us. So definitely welcome. So Dr. Runge, I want to open up with this question. When you look at the current American health system, what's that one thing that make you feel like we really need to fix the health system? Yes, the old ways are no longer working. That's obvious. But the new approach sometimes could feel very disorganized, and it's something that people are trying to catch up with, and that could be very complicated. But between the old and the new, there's a lesson to learn from there. If we have to move healthcare towards a transformative process where all of these things come together to make rural America truly healthy, what is that particular thing?
Well, I think that the missing element, it's really two things, but they're very related, and that is the paucity of primary care in the United States. You mentioned the cost of health care in the United States is high. And despite that, if you compare how many primary care physicians we have per 1,000 people in the population, we're at the very low end of peer countries in the world. So we don't have enough primary care. And I think it's pivotal to have primary care and a care coordinator for people who have health problems, not only to help their journey through a very complicated health system, which you already acknowledged, where we have terrific sub-specialized medicine, but it can often feel to individuals hospitals, myself included, that it's disjointed and nobody's talking to each other. So primary care can help fill that gap. But I also very strongly feel that we are missing opportunities in terms of health and prevention of illness. And when one thinks about the cost of healthcare in the United States, part of that is that people don't get to the hospital, and there's a host of reasons to it, until they're very ill, and then their hospitalizations are long, or maybe they don't have access, and so they have to come to an emergency room, which is very expensive and doesn't provide continuity of care. So I think I would love to see us, and I'm highly supportive of this, shifting some of that focus to primary care, health prevention, and really the concept of health, not just health care. And I think it's the responsibility of healthcare providers, of policymakers, of all of us to recognize that that's a limitation in the way healthcare is delivered in the United States.
I totally resonate with you. And as someone who comes from Africa, where when we look across health indices, is always lowest rung of, the global health indicators. It is surprising for me when I came to the US to see that some of the indicators, even Nigeria is competing with the US. And that was like one of the biggest shock to me. I mean, I understand like there's this high level of medical innovation, yet those particular indices, and I know we're going to talk a little bit about it when we move along in talking in more details in your book, where you would see third global south countries having almost the same similar, for instance, if we use maternal and newborn, child mortality, you see almost similar indicator between the US and some of the global south countries, where you think that things should be far worse than a country like the US. So it's fascinating, not in a good way, to come with this shock for me that the US is grappling with this kind of indicators. I know we compare that a lot with, the global industrial countries like the OECD country to figure out, okay, this is where the US places itself, right? And then let's do that analysis and see where the US sits amongst these countries that have similar dynamics and indicators. But when you remove the US and place them in this other side of the statistics, you start to see similar indicators as well, which doesn't say much about where the US health system, especially primary healthcare, sits. But before we continue, let's take a quick break. If you are enjoying this conversation, don't forget to subscribe to What About Rural Health on our podcast streaming platform. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please leave a comment, share, and most importantly, leave us a review. It helps others discover this important conversation. All right, we're back to the episode, and you are still listening to What About Rural Health with Chinasa. So, Dr. Runge, let's take this issue one after the other. The tripartite problem that we mentioned and discussed earlier, physician shortage, the high cost of delivery, and the persistent gap in primary health care is very real. And I believe you've spoken about it in your book in detail, in far more detail. But when we look at these challenges together, how can the American health system reappreciate the importance of strengthening that foundational layer of healthcare delivery, not just the basic part, but the baseline that makes people healthier? Because without a healthy economy, I don't think we will continue to thrive as a developed capital country like the US is.
Well, Janasa, let me follow up on two other comments you made. And the first is about health and comparing in the United States. And I learned a lot about all of this, things that I thought I knew and that I didn't know in writing the book. I will show people, in case your audience is there, this is what the cover of the book looks like.
Yeah.
And there's an indicator called Healthy Average Life Expectancy, HALE, and that I know you're very familiar with. And the concept there is not just how long do you live,
Yes.
when do you die, but how long do you live in a healthy manner so that you can do what you'd like to do. And what was a total shock to me, I have a table on it in the book, was that the United States ranks 60th, 60, among all countries in the world. And that's just discouraging. And if we don't change what we're doing, that's projected by some of the best epidemiologists in the world, that we'll be more like 110th in 2050. So I think it's a call to action. The second thing I just want to comment on, so I don't lose a train of thought on this. You talked about how people who, and particularly physicians, but others who go into rural health, do it because they have a passion. And in our medical school class, probably a quarter of the class wants to do primary care on the day they come to medical school. By the time they graduate, it's less than half. And there are lots of reasons for that. There's debt, there's the push to be super specialized that comes through loud and clear to our students. And I don't think they have the best opportunities to really explore the benefits of being a primary care physician. And so I'll come back to those points, but in answer to your question, I think that we have to make primary care in rural settings, we have to make it accessible. And what does that mean? Well, it means being able to be seen, be heard. Telehealth was a big step forward that occurred during COVID, as you know. And we went from doing about 2% of our visits in telehealth to almost over 25%. It's settled down around 20 or 21%. But for people, whether they live in a rural area or anywhere, telehealth can be a big advance. There's also a lot of potential here in the last year. If you'd asked me a year ago, I would have said no, but in terms of use of AI, and I think that has lots of potential in rural health. And I just want to give you a couple of personal anecdotes. So I'm a cardiologist. I ended up in academic medicine. That's not where I was headed. One of my role models was an uncle. I had an uncle who lived in Del Rio, Texas. When he was there, it was a small community right on the Texas-Mexico border. We'd go visit him. He had a two-way radio that his wife would call him on, and he'd be seeing patients all over, some in Texas, some in Mexico. It was before border problems. And I thought, wow, that is so cool. And later in my career, when I was in North Carolina in particular, I had the chance to work in rural settings. So North Carolina is a fairly rural state, and there are clinics that are called federally qualified health clinics, or FQHCs. They're supported by the federal government. And when people talk about how the government doesn't do a good job in healthcare, they obviously have never been to one of these clinics. They do a fabulous job. And we may talk about it later, but this concept of a medical home. So if I'm having a problem and you're my physician in the FQHC, I have a problem, I come in. I can come in the same day. It may be that I need to see you, but it may be I don't need to see you. Maybe I need to see a advanced practice provider like a PA or a nurse, or maybe a medical assistant, or maybe I have a dental problem or an eye problem. It's all there, and they work together. And the people who work in those clinics are so passionate about what they're doing. I think if our medical students and early trainees can experience that, and we're trying to help them experience that more now in the state of Michigan, that could really change their trajectory. And I think it also speaks very highly to what can be done by the federal government and is inexpensive. If you compare it to the cost of programs that are run in other ways, the cost of this is tiny. And the reason it's tiny is because the people are so passionate about what they're doing. It's rewarding. I used to go half a day every other week to help with cardiology problems. It was in a tiny town called Moncure. I don't know, the population was probably 800. And it was just a great experience.
Thank you so much for that story. One thing I wanted to add in follow-up is this. I think we look at pockets of success of where rural health is functioning. This is always the story that I passionately hear both physicians and the patients who access health care in such environment. This will be the kind of passionate story that they will tell me. Versus when you go to communities where this is absent, and then the story becomes different. And it's like two parallel experience from two different people depending on where you are at and the time that you are in. But at the center of this question that I'm trying to ask is, every day we see more and more complexities in the U.S. healthcare systems generally. Either more regulations are being introduced that is making it difficult for people to practice things, the way that they understood them earlier on, or just the infrastructure is now making it a little bit complicated to navigate all of those things that at the end of the day, the actual care delivery is being stifled out. So my question to you, and I think you talked about it in your book as well, that there's need for us to have technological advancement in medicine. But there's also that thing about simplifying certain healthcare systems so that it makes it easy for people to access those. So which part of that level of healthcare would you say, oh, let's simplify? And which part would you say, oh, this is okay for it to, continue to be a complex thing that requires complex technology to implement?
Well, I'll start with the latter, which is high complexity healthcare. If I'm really sick and I have a very serious health problem and might need a complicated surgery or might need a bone marrow transplant, there's not really any place other than the United States that I would want to get that care. So that level of care is excellent. It is fragmented, as you've said, and I think we can make a lot of progress by making it less fragmented. And some of that has to do with interoperability of electronic medical records, because somebody may be going to a clinic for their bone marrow transplant, but their main care is somewhere else. And we still have a ways to go with that. However, on the simplification, I think you have really picked up on a very, very important point there. Why should it be so complicated? And why can't we make it simpler? And I'll give you a couple of examples that I think are important, but they're not. Maybe one is more apt, more appropriate in rural health. But because most practices and most health systems have great difficulty with access, meaning you call for an appointment, it's hard to get one. It's a maze you're trying to walk your way through. There are other approaches. Take, for example, Amazon and Google both have clinics, and somebody's available 24/7. They can prescribe medications, help you get medications. But we need to learn from that and not try to say, oh, we can do better than that, because that study's already been done. We cannot do better than that for instant access. I mean, that's why they're doing that, and that's why people appreciate using it. So we should embrace that.
Mm.
But I think we also have a lot of ways to go to make it simpler. And there's several places now that are using AI for scheduling. And so it used to be you'd call a doctor's office, and it could be a long process. Then you call a health system, and that could be very complicated, take a long time. Seems like the doctor you need is never available. With AI, it's possible for AI, just in the way it does in every single way, to look at the problem. AI looks at problems and says, what is the problem? We tend to say, here's a solution, let's try this solution. But it looks at the problem, develops solutions. And one of those is that it can look at all templates for all physicians. And they might find out that every Thursday at 11 o'clock, I block off an hour in case somebody needs to see me. Well, if that were the case, a lot of times that hour wouldn't get utilized. They make sure that hour is utilized. And when you multiply that by tens or hundreds of physicians, that creates lots of access. But it's something that's hard for an individual person to figure out, where AI can look at it and almost simultaneously say, okay, well, here are 3 doctors in the area you want to see that have cancellations that are available tomorrow. I mean, imagine that. How often does that happen to somebody? So, and I think just using some of these tools to help patients, to help all of us navigate the system, is a use of AI that is available today, and we need to embrace it. Coming back up for a moment to Amazon Clinic, saw a guy who's a long distance truck driver. He and his wife drive across the country back and forth. And it's really hard for him to have continuous health care. Ran out of or lost his antihypertensive medication, was really worried about it. He'd had trouble with his blood pressure. So he'd heard about the Amazon Clinic. He was in the middle of nowhere, and he called and got somebody on the line, and they said, okay, we understand your problem. You're 30 miles away from Moncure. You're 30 miles away from a tiny town, but they have a pharmacy. We'll call ahead, and your blood pressure medicine will be there for you when you get there. And, I just think that's a great example of how, and that sort of thing happens in rural medicine all the time. And They may be from one small community, but they're out working somewhere else.
Mhm.
And the only piece that's lacking for that, that I already talked about, is interoperability of electronic medical records, because Amazon doesn't have a way to link with the Epic system at the University of Michigan, nor vice versa. I truly believe that that's a problem that is not easily, but solvable. But frequently, health systems and electronic medical records have not tried very hard. This has been around since the Biden days, or before Biden, that we need to have interoperability in electronic medical records. And I think until this is one of those areas where the government has to step forward and say, okay, here's what we'll do. You don't make your records easily accessible in a safe way, we don't pay you anymore. That will get people's attention. And, I'm not a fan of the government having a heavy thumb on things, but I think there are some key areas where the only way it's going to happen is with consequences for systems that don't agree to do what the government would like it to do. And I think the government is all about being able to have healthcare be accessible, and then we can use our money wisely, and then people don't get so sick. And that guy driving across country, instead of having a stroke halfway to California, he's got his blood pressure medicine.
Thank you for your response. I do have a follow-up question on your response here about the usual concern for data safety and security, because it seems like there's just this hyper ultra anxiety about, what would government do with our data if they have such enormous control over data democratization within the healthcare industry. But beyond that, like, what would also be your response? Because oftentimes people are worried about company like Amazon, for instance, using integrated AI to do all of these things, but also the high sense of what the algorithm is doing now, where it uses to do targeted marketing, etc. and etc. I mean, these are speculative anxieties that people have, right? But at the same time, these are also processes that we can use data to improve healthcare access and usability. So what would be your response to this kind of concern?
Tough question. I'll try to answer it. So first of all, I've spent my time here at Michigan trying to be sure that we protect patient data. And I would say, just being self-critical, we were rather lax about that when I came. And we had to put in processes that, again, had consequences for people that were roaming medical records. Now there's enough sophistication of medical records to be able to find out when people do that. We have one of several systems that scans every single medical record, 4 million medical records a day, every day in Michigan, to look for inappropriate access. So I think we have some tools. I do not think the government ought to either own or be allowed to dig into PHI. So this came around about early in the year, about the government wanting to probe Medicaid databases looking for illegal immigrants. I mean, there is nothing I can say that's a positive about that. It puts all kinds of risks there. So I think the government should not have access to our electronic medical records or our data. But I think they, as the biggest payer in America, they have the ability to make that absolutely necessary for providers and health systems. The last point I'll make about that is that when we think about using AI, I think that AI needs to be held to a very high standard.
Yeah.
Just as high for any other provider. So there is also a push, well, let's just push out all these AI solutions. I don't think they should be pushed out until we know that they are excellent. And in doing so, that will make it also possible to protect PHI. A couple of examples of that are, or maybe the best example is people expect perfection out of AI. And somebody or another said that don't ask me to be like God, ask me to be better. And because you can't be perfect. And but I think we can all see a day when an AI-driven system or approach results in a patient death, and that's going to be front page news. Not that there are medical errors in medicine all the time. The the analogy I think of is Waymo, which I don't know if you know Waymo, what or your audience. Waymo is totally automated vehicles. They're very prominent in San Francisco. So you can call an Uber or you can call Waymo and this car shows up. There's no driver. And Waymo has driven 100 million miles with no fatalities. I mean, that's incredible.
Yeah.
And that's so much better than any group of human drivers. But you can be sure the first time there's a fatality, that's going to be top news. So we told you so. We told you that wasn't.
Yeah.
And so in healthcare, we just gotta stiff arm that and say, no, we didn't tell you it was going to be perfect. We told you it's
Yes.
going to be better than the alternative, and we need some better than the alternative solutions.
I like your response. Thank you so much, Dr. Ranjan. I want to shift this back to the conversation back to costs because, I mean, cost is very central. It's abundantly clear that there are things that are driving healthcare costs in the US, and those things are inevitable. For instance, the cost of medical innovation, like all this AI, technology, data management that you're talking about. Someone, bears the cost to set up those systems up, right? In order for us to deliver precision health more effectively. But then there is also this other part that is a concern for especially people in low-income environments and rural health, specifically in rural environments, specifically, are always concerned, with all of this technological advancement, is going to just continue to widen the gap between those who can afford this cutting edge care and those who would not. Do you have a rural health stories that need to be heard? Whether you are a health worker, patient, policymaker, or advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with detail on how to get your story published on our newsletters, websites, and other media platforms. How do we now strike that balance of making sure that this innovation that is inevitable would continue, but at the same time that we are ensuring that rural American people are not priced out of or left out of quality care because of this high technological advancement that we're seeing?
United States is a very entrepreneurial country, maybe the most entrepreneurial. And a lot of innovation, as you've been talking about, comes from that entrepreneurship.
Yes.
However, I think that we have to figure out how to make that affordable. And I am very concerned about what you just talked about, the growing disparity among the haves and the have-nots. So let me just take AI as an example. I think the people who are developing these AI solutions, they should get financially rewarded for that. However, I think we have to put guardrails around it, because if it's going to cost as much to have an AI solution as it would be to hire another 10 healthcare providers, that's ridiculous, because once it's in place, it can be used over and over and over and over and over again. So I think that's true with many technologies, but I think that is going to be a pivotal point in my judgment of AI, is whether it can be made affordable, and so it just doesn't end up being another big cost for the system. But to speak more generally about it, there is so much waste in our system, financial waste. So you talked about it earlier. I'll just give some data. As of last year, the average cost per person of healthcare in the United States was over $12,000 a year. If you look at other high peer countries, it's 6,000 in Germany,
5,000,
5,000, 4,000, 3,000,
3,000,
and
yeah.
for excellent healthcare. So in the United States, it's 2 or 3 times that high. And why is that? Well, some of it's technology, but a lot of it is this medical industrial complex that's been built. So to take a common example, people talk about, why do medications cost so much? Well, part of that's the development of new medications, but then there are layers of complexity, layers of people taking money out. For example, I talked a good bit about pharmacy benefit managers, PBMs.
Mm-hmm.
I fail to see any value to people in that. Zero. I mean, I'm being serious. If our conversation gets interrupted, we'll know they control the airways also. But that was inserted to make money for investors and to make money for insurance companies. And the transparency for trying to understand that, I've studied that over and over again, and I believe I understand it, but it's so complicated. Nobody could possibly follow it. And it's a series of rebates and all kinds of crazy things. I want to kind of get back to the baseline of your question, which involves, in my mind, and I know we're going to talk about this a little later, the federal government providing some base level of health care. I'm not saying it has to be gold plated, but almost every other country has some level of government provided health care, and that's good for health. It means that you can have access regardless of your financial circumstances, and you can be preventing diseases from getting worse. And I'll make a couple of additional comments about it. So people say, "Oh, the government is expensive." So if you look at administrative costs of healthcare, this is just for an insurance company how much they charge to do all their processing of claims, advertising, everything else you can think of, money back to their shareholders. That's about 16% in the United States. It's lower in other countries. Guess what Medicare is? 2%. So the argument cannot be that the government provided healthcare is too expensive because of administrative costs. It's just not. So now trying to change all of this is a highly politicized process. I will say that when I talk to my friends who are on one side of the political spectrum, they say, well, that would bankrupt the government. We can't pay for everybody's health care. And I'm not talking about all of their health care, which I explain to them. And I say, plus, if they're healthier, they're going to spend less money in hospitals anyway. The other side of the political spectrum says, we cannot have, I won't stand for two tiers of healthcare, meaning that the government level would not be as high as commercial. And to which I respond, look, come on, get a life. We have at least three tiers. We have commercial, we have government, we have concierge care for those who are wealthy, and we have no health care. And the United States has no health care insurance for a very significant portion of the population.
Yeah.
So we can't pretend like we don't already have different levels. I'm just saying we need to have a base level that would help people.
I like the way you lay out all these tiers so that it's easy for us to, because sometimes I think missing that makes it difficult for even individual human being to pause and say, okay, where can I get basic health care, assuming I'm sick? And I know many would argue that there's emergency care unit, but that is not what basic health care is supposed to do. You are not supposed to be rushing to an emergency care unit just because, the reason why you would rush to emergency care unit is because there is no established basic care that you start from.
Yes.
And even when there are PCPs everywhere, most are private practice, most are embedded within hospital, and most are the federally run hospitals that serve underserved community. Yes, that is there, but it's also about behavioral science. Like, do we as regular Americans even know that there is basic care, or there should be basic care, and what should constitute that? In Nigeria, where I come from, we have what we call minimum service package. That is very basic, and those are places you will see the vaccines, the malaria treatment. They are very basic, and they are at the grassroots anywhere. Whether you have money or not, you have those basic care service because they are structured policy-wise for every citizen, irrespective of how economically buoyant or not that you are, to access that basic minimum service package. And that's, leads me to my next question, obviously. I am in some way part of those people that think health should be a right? However, that conversation is like, okay, health should be a right, full stop, what else? And then we see on this side, there is the entrepreneurial part of health, where innovators and business people really have to establish processes and platforms that they do cutting edge medicine. And then there's this part where health should be understood to be a social good that should be delivered to everyone. But these two things may or may not come together depending on who is playing the role. So what I wanted to learn from you is, from both the government and business standpoint, what perspective needs to shift in order for us to bring this to paradigm, or what would I call it, in a more closer way that we could deliver more better patient-centered care to people in rural environments?
Well, you put that together extremely well, Janasa, in terms of what the problem is. And I like the fact that you brought up emergency rooms because right now they're the fallback. And so whether you're having a stroke or a heart attack or you're in an automobile accident, or whether you just you don't feel right and you think you need to be seen by somebody, everyone goes to the emergency room. And our emergency room here is not atypical. People on a great day might wait 2 or 3 hours to be seen. On a not such a great day might wait 6 to 10 to 12 hours in the emergency room. And it's, as you said, it's not continuity of care. So again, thinking about, you probably heard this term design thinking. Have you heard that term?
Yes.
So I think of AI as design thinking. So it's not like here's a solution, where do we put it? It's like, what is the problem and how do we fix it? And that's what design thinking is all about. You go to a factory or you go to a store and you see, well, what are the problems they're having and how might those be addressed? In terms of access to healthcare, I can imagine a day, but it's going to take a lot of education and a lot of public promotion that everyone has access to some sort of online, either telephone or online or basic tier, kind of like what you're talking about in terms of Nigeria. I'm impressed that Nigeria has that. What did you call it? The minimal?
Basic minimum service package.
Yeah, the basic minimum service package. And so what would that enable if we could do that? Well, that would enable somebody to, their primary care doctor is not going to be there 24/7. They just can't. Enable them to have a line to call and say, well, here's what my problems are and what should I do? And have somebody qualified who says, well, you better get to the emergency room, call an ambulance. I mean, that's one situation. The other situation is it's probably fine to schedule an appointment with your primary care physician or their practice or their group tomorrow or the next day. And I can help you with that. I mean, an AI scheduling system. Or to say, your symptoms are very much like what has been going around, some sort of viral infection. I don't want to underplay it, but why don't you start by being sure that you're drinking plenty of fluids, you're hydrated, and you don't have a fever. And if that's the case, please check back with me, the person or the bot or whatever. Check back with me in 4 hours and let's see how you're doing. But if you're doing fine, you don't need to go to the emergency room. And chances are you'll get even more ill going to the emergency room. You might pick up what other people have.
Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from researching to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
So it's easy for me to say that. It's hard to implement, but I've heard people say these solutions, they're just too hard in healthcare. They're too complicated. I'm going to go back to my Waymo example. I mean, how can you come up with a way that a car can navigate traffic in San Francisco and, not be running over people or just throw their hands up and stop in the middle of the street? We have the ability to do that, and we just need to apply it, in my opinion.
I think I agree with you. And being someone that have probably 1,000,007 things that I do in a day, God knows that technology is one of those things that help me get by, including reminding me you have a doctor's appointment by so time, because I do have those integrated assistive tool that help me keep up with things like that. And I know there's always this concern, especially when there's new technology, about what these things are doing versus human interaction. And that is where I want to take this question to. Some people would say, well, I'd rather speak to someone than, talk to a bot and have this delivered to me. But I've had an earlier guest who has an AI tool that is called Huron AI and is nurse, I think it's nurse navigation assistant. I want to remember that for people with cancer, and he's doing well with that. is helping patients navigate care within those who have cancer within the care system. Just being able to say, okay, oh, this is how I'm feeling today. And because these things are already embodied, and please, I do, it irks me when I hear the conversation about, AI is doing that. It's humans behind the AI. I hope we just know it's digested data over time that's, linked to certain things. So if you put in data that looks like this, the AI might look into the system and give you something that looks similar, because over time it has a history of these kinds of data and what they could mean. And it's people that impute them there specifically. So it irks me when I hear this conversation, and I agree, there is that human connection in healthcare delivery. But there is also the thing that we understand that it's not effective, in the sense that the ratio of physicians and health practitioners to the population is too wide. There are places where we need to cover this gap, and that's where technology comes in. So the argument should be balanced in that way, like you talked about San Francisco, and the Waymo cars, very amazing, versus, you live in San Francisco with so much traffic, and you would say, no, I don't want this kind of precise car that would navigate traffic or figure a way to take me out of traffic and get me to my destination as quickly as possible. So that is the balance that I wanted to just throw in this conversation. But I want to bring this to my audience. Before we continue, I want us to pause a little bit and think about what healthcare accessibility truly means, especially for rural communities, because sometimes it seems like as long as you are able to see a doctor physically, then that is healthcare accessibility. But we've gone past that. In this new age and time, it's a whole lot of bucket of things that has to do with how investment is navigated within the system, what one can do that gets us to preventive care, the everyday infrastructure that keep people healthy. All of those things come together to, in my own view, to define what we should see as healthcare accessibility. And that is how broad we should be able to expand our ability to understand that. But I want to also ask a question as you reflect. What would that look like in your own community for you to genuinely say that you do have the ability to access care? Drop your comments in the comment section. And to everyone listening, thank you for joining us on today's episode of What About Rural Health. If today's episode moved you, challenged you, or made you think a little bit differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let's keep asking the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.